So that's surgery. Glad we got that solved. So let's discuss something that we also is very clear and has been definitively studied: intraperitoneal chemotherapy.
Of course.
So we're all
Very straightforward.
We're all familiar with this study, GOG 172, and I published in the New England Journal by Deb Armstrong. I actually call that study dose-dense weekly IP therapy because it was dose intense, and it was weekly, and it was intraperitoneal. And the three things that they changed, there's an important difference, and led to an NCI alert, and PFS and OS difference. So then you decided on a definitive trial 252.
Oh, why are you looking like that?
Because I want you to tell us about it.
Definitive trial?
That's what you decided we do.
You just said 172 was a definitive trial.
So
it takes 2 trials to convince anyone of anything.
We had 3.
Well, we had 3
already.
already.
Yes,
Okay, let's hear what we.
Well, so first of all, it was a panel, it was a group of experts at the Gynecologic Oncology Group, which we were all a part of that, right?
Okay.
And there's several great leaders in IP therapy, and I applaud them for all their efforts and their years. And this study was a little different than in terms of the other studies, but there's 3 arms. There's a dose-dense IV arm with paclitaxel and carboplatin. There's a dose-dense paclitaxel arm with IP carboplatin. And then the last arm was basically a modified GOG 172 with paclitaxel on day 1, a shorter duration of treatment, day 2, cisplatin IP with a lower dose, and then you have day 8 of IP paclitaxel.
So a 3-arm trial, we all agreed on it.
Yes.
And it was 2 arms IP. And how'd it work out?
Well, hang on.
Wait a minute.
Every arm also had bevacizumab, which was a decision that was made at the time. Was that your fault?
No, bevacizumab's a great drug.
It is a great drug, but I think one of the problems with these different arms they chose is they didn't have the standard arm. What was considered the standard? There's no control arm. It was all these other arms. So, but let's just.
Who planned this study? No, I'm kidding.
So the control arm was dose-dense weekly paclitaxel and bev. Maybe that's not the standard, but in the study, that's what was the standard.
That's what it came to be. And there was 1,560 women who participated in the study. I mean, that is a tremendous effort.
And tell us about the difference in the arms.
And you mean the clinical
differences? PFS, OS.
Endpoint,
I'm
maybe.
getting there. I'm getting there. So they were the same, and it was 26 about 26 months for the standard care arm, 28 months for the IP carboplatin arm, and the IP cis arm was 27 months. So that was all the same. The kicker here is really the toxicity. The toxicity was worse in that cisplatin-containing arm with more hypertension.
IP was more toxic. Yeah, that's surprising.
Cisplatin IP was more
The
toxic
drama is
when you
killing me.
combine with bevacizumab. So Brad, you're an IP hater.
I'm not an IP hater. I'm a disease. I'm a data lover.
You have
So what's the
not
conclusion of
liked IP
252?
for a long time.
3 arms.
Wait. Before you go on there, why don't we talk about the eligibility? Because I think that's important. So
Go ahead.
No, go ahead. Because I think it's important that we understand exactly who we're treating, who are eligible for the study.
Well, it was patients with advanced stage disease who were optimally
Less than a centimeter.
debulked. Yes, less than a
Less than a centimeter.
And what are you alluding to specifically?
Mainly because when people look at data in all these different studies that we're quoting, they're all looking at those median time points, and so even though they're not supposed to, they all look to see how they rank up relative to each other. And so when we
So in this study, the R0s, they did better they got IP?
Well, they did. No. I don't know if we have. That's about the same. It's about. They did. They had R0s. They had a lot of R0s in the study. I think it was like at least 50%.
And it still didn't help.
But listen to this. It's very different. It's a different group of patients, I think, than GOG 172. Because if you look at the R0 group, and I think it's Chip Landon who wrote the study, the R0 group in the GOG 172 study had a survival of over 70 months.
Right.
I mean, it was outstanding. And the PFS, I think it was actually PFS maybe, but PFS for this group was about 30 months across the board for the R0 patients. So there's something different about these patients, and it could be that we're more aggressively debulking patients than we were in the past for GOG 172. And I'm not sure what it all exactly entails. And maybe bevacizumab is the greatest equalizer, so that could be part of it too.
So this is a serious discussion, and a 1,500 patient trial, given all its frailties, did not meet its primary endpoint. Does this answer the question of IP chemotherapy, or do we still need to continue to debate it?
I don't think it answers the question of IP chemotherapy. I think, unfortunately, we've learned a lot.
What did we learn?
We've learned that we had none of the important stratification factors, well, not none of them, but a lot of the important stratification factors we know now, BRCA status, HRD status, none of those are included in this study.
It's randomized, they're equal.
Well, I think we've learned from other ongoing studies that randomization actually doesn't guarantee equal distribution of those important prognostic factors.
It's true.
So you think the reason it's negative is because there's randomization error?
I think that we can't confirm that we have equal groups. I think we tried to ask, and actually this was brought up in an excellent ASCO discussion, we tried to ask too many questions. I think that even though we think that the timing of Taxol 3 versus paclitaxel, 3 versus 24 months shouldn't matter. It might matter here. The dose of cisplatin may be important. There were too many things changed in 252. We used less cisplatin. We used 3-hour paclitaxel. Those are both different than 172. And we added bevacizumab, and we didn't stratify. So I think it's a great study. We did a great job. There's good data. The results are what they are, but they don't answer a question.
We did a great job. We had 1,500 patients. We didn't answer any questions.
Well, but Brad, look at it this way, though. We have a trial in a contemporary setting that we achieved one of the highest progression-free survival rates across the board for all those 3 arms. So rather than
including the
emphasize the negative, I would emphasize the positive.
And I'm not trying to pick at you. It's just this is the end of the story. There will never be an American IP trial ever again.
So I was going to bring that up. So the question about IP versus no IP, really the outstanding remaining trial is the IPOC trial,
which is a Japanese trial
that Keiichi Fujiwara is doing, and in that particular trial, the only variable is the IP. It happens to be carbo, and everybody's getting dose dense, which, as you know, in their patient population is important. But I think it also brings up, and it's a good segue into 262, because when we talk about what's the drug-drug interaction between these factors, and I think what Angela's mentioned is probably important, that there may be some equalizing factors that are catching one of the arms up that we missed because we did too many things at once. You know, IP, adding the bevacizumab and weekly paclitaxel in 262 didn't seem to have the additive benefit we would have expected to see based on...
Tom, tell us about 262.
Well, let me go back to IP. I couldn't get a word in edgewise because you guys are so animated.
That's surprising.
But I think that, you know, this is a very serious thing. A lot of people have dedicated their careers to this and so forth. But I have to say, you know, we have to look at the community acceptance of IP going into this trial.
Right.
It was very, very low, and there's nothing about this trial that makes you want to, you know, continue to investigate IP. So I think this is a big problem, and this was the opportunity for those who were the biggest believers in IP to get it right.
Thank you.
And it for whatever reason, and it may be all the things that Katie just said and Angela's just said in terms of we changed too many things, we reduced the dose. It may be that the regimen from 172 is superior. We don't know, but unfortunately we didn't have that as one of the arms. So I think from a practical standpoint, it's pretty dead.